Good evening and welcome to the EUROGEN webinar series. I'm Michelle Batty and I'm the manager of the European reference network that we call EUROGEN. And EUROGEN deals with rare urogenital diseases and complex conditions that all need highly specialised healthcare. And at the moment, we're a network of 56 healthcare providers in 20 member states. And what we aim to do is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment, and care for patients with rare urorectogenital diseases and complex conditions. So, some of the activities of our network, we do virtual consultations, as you can see from behind me, and we have a very secure platform that was given to all of the ERNs by the European Commission so that we can conduct cross-border secure consultations so that the expertise can travel across borders and not the patient. We also do training and education activities like this webinar series. We write clinical guidelines together, and we also have a EUROGEN registry, which will be very exciting moving forward because we can collect the data which is fragmented on patients with rare diseases and often scattered all over Europe. And we've also produced this really wonderful book on rare and complex urology, published by Elsevier, where we bring together all the latest scientific knowledge across the whole of the network to help improve care for our patients. So without further ado, the speaker in our webinar this evening is Professor Oliver Muensterer, and he is going to talk about lichen sclerosus in men. And he's obviously a member of our network, and he's from the Department of Pediatric Surgery in Hauner Children's Hospital, Munich, Germany. And in this webinar, Professor Muensterer will review the disease burden and impact of circumcision on men with lichen sclerosus, particularly focusing on sexual quality of life, possible therapeutic strategies, and implications for circumcision. So thank you very much, Oliver, for sharing your experience with us this evening, and you have the floor.
Well, so thank you so much, Darren, and also to virtual Michelle for the introduction. And hello, everyone, to this webinar. It certainly is a great privilege for me and a pleasure to be part of this. I really actually enjoy the webinars myself, usually passively, and today actively. And yes, today I'm going to be talking about lichen sclerosus in men and boys, obviously, because I'm a pediatric surgeon. And these are my disclaimers. Really, nothing that really has anything to do with lichen sclerosus. And you will ask yourself, well, how does he get to that topic? Well, we pediatric surgeons, of course, do a lot of circumcisions, and I've always wondered, is like 10% of my paths. I send all the foreskins in for for a pathology review, and about 10% I looked at just recently come back with lichen sclerosus. And I used to say, that's great because the therapy is circumcision. And I used to counsel the families and say, this is, your son had this entity that's very rare, but happens in the circumstance stance. But the good news is the therapy is already part of the deal. Circumcision is usually cures it. And then I was at a meeting, and there was the Lichen Sclerosus organization in Germany, and there were 3 women there, and I wondered. I asked them, do you have any male members? And they said, yes, we do. And I said, that's very unusual because don't they usually get circumcised? and then that should take care of the problem. And it's the easiest thing in the world. And I said, well, that's not so easy, and that made me get into interested in this. So actually, when I was still in Mainz, I worked together with who is now Dr. Anja Zillinger. She was a medical student at that time, and she's now in the Department of Gynecology in Mainz. And we put up a, a study on this, and that's part of what I'm going to be talking about. So, for those, I mean, lots of you will already know, but lichen sclerosus, or also known as Balanitis xerotica obliterans, BXO, is very debilitating. It's an inflammatory disease of the anogenital area, and there's very little known about the etiology. It is immune mediated. It is associated with certain infections. There is certainly a genetic component to it, but honestly, we don't know much more about it. And it typically affects postmenopausal females. So there's also um, this hormonal influence to this disease, and but it also presents in men and even in boys. And if you do circumcisions, and I mean, I'm sure you guys out there are urologists and pediatric surgeons, this is part of your life, you will encounter this. And it's more complex, I found out, than I thought a few years ago. So typically, this presents with white, atrophic, chronic, pruritic, painful patches of the vulva and the penis, and it's particularly affects the foreskin, and it can affect the glans penis, and it can cause pain, it can cause itching, it can cause sclerosis, and it can cause meatal stenosis and things like that. And in the long run, it's also considered a precancerous lesion for squamous cell carcinoma. So, this is rare, but it can become malignant. So this is something that I think we have to pay much more attention to than we are actually now. So I told you about 10%. I looked up my numbers, and they're 10%, and they've been pretty much 10% stable throughout my career. If I look at the path reports, but if you read the literature, I mean, there are reports out there, depending on the setting, where you can have much more of foreskins coming back BXO positive. And this is a recent report from just a couple of years ago, and they looked at all kinds of like they did a systematic review of all publications on this, and it's much more common than you think. So, as I said, circumcision is generally considered the first line and definite treatment for lichen sclerosus in boys and men. But if that's the case, then that would be easy. Then I wouldn't have to, talk about it, because, you basically do a circumcision and that's it. But like I said, I met these ladies from the Lichen Sclerosus Germany club, and it's surprising, but there's about 250 members, and about half of them actually have lichen sclerosus themselves. The other half are like supporting members, probably husbands or partners of women that are affected. So, and of those, about half underwent circumcision, and the other half didn't. So even the ones that had a circumcision are not necessarily cured. And that's something that is kind of was a new concept for me. What is the role of circumcision in the treatment of male lichen sclerosus? We're going to talk about that. What is the impact of circumcision on disease progression, and what is the impact of circumcision on sexual quality of life? So we performed an online survey among male members of this organization, and what we wanted to look at was their disease extent, their symptoms, progression, and what they had as previous treatment. And this impacts significantly on many aspects of your life, but especially on sexual quality of life. So we figured, is there something that is there some tool that we use to quantify and to objectify sexual quality of life? And actually looking through it, there is a published tool that measures sexual quality of life, and it's called the SQOLM instrument. And it is something that actually was made with, this is a disclosure, with the help of Pfizer when they brought out Viagra, like a long time ago. And so they put this up, and it was their idea to sort of quantify sexual quality of life. But you can use this for all kinds of aspects of sexual quality of life. So, like I said, there were in this organization, there seemed to be people that are, or men that are circumcised and others that are uncircumcised. And the question was, what was the impact of circumcision on all of these things, on disease progression, on other therapies, on medical therapy, and so on, and on sexual quality of life. So we had a total of 281 members, male members, and of these, a surprisingly high rate of people responded, 225. Of these, 100 were supporting members that did not have lichen sclerosus, and 125 actually were those that had lichen sclerosus. And of these, 33 did not complete the survey or didn't complete it entirely. So that left us 92 surveys that were completely completed. And of these 92, there were 48 men that were circumcised and 44 that were uncircumcised. So we had a pretty, let's say, balanced distribution. And so we compared these groups. So these are the demographics. The non-circumcised were a little younger in age. So you'd think, maybe they haven't been circumcised yet. And the other parameters that we looked at were really, there was no difference. Even in ongoing corticosteroid therapy, avoiding symptoms, itching, burning, pain during intercourse, as sort of male dyspareunia, was pretty much the same. And surprisingly, this already shows you a little bit that this is a big problem. If you have lichen sclerosus as a man, you're very likely to have painful intercourse and thereby an impact on your sexual quality of life. So 19% with lichen sclerosus reported a family history. So there is some kind of a genetic component to it. And that is pretty much in line with what the literature says. And another thing that I was surprised, because if you read it, there are a lot of reports that link lichen sclerosus with Epstein-Barr virus infection or Borrelia burgdorferi infection, so Lyme disease. But in our publication, or in our survey, there were only 3 of the 125 men that that remembered an EBV infection or Lyme disease in the past. So that is markedly lower than what is in the literature. Now, in the literature, most of these cases that are reported are women. And we don't know, unfortunately, this is where there's more work to be done to see whether, sex as in gender, plays a role in disease modifying infections like Epstein-Barr virus or Lyme disease. So this is basically what we found. So it's a little bit, this graph, there's 2 different scores that you get. In most of the items that are asked, you get a score between 1 and 6. And these are the median. So you won't see much of a difference. And actually in the items themselves, in the individual items, there was no statistical difference. But if you put them all together in the compound score, which goes from 0 to 100, then the circumcised men had a significantly higher sexual quality of life score than the non-circumcised men. So the other things that we found was that circumcision was associated with substantial improvement of genital symptoms, particularly pain, fissuring, and dyspareunia, male dyspareunia, although the individual differences do not reach statistical significance. And the majority of circumcised patients reported either complete symptom resolution after the circumcision or a marked improvement. So that leaves the question, why are there not more men circumcised? And that's a question that we couldn't answer from our survey. And I guess in follow-up surveys, the real question is why are these men not the group that was not circumcised, and are they planning it? Is there something that is that they're considering, or what are the reasons why they're not considering the circumcision? Now, this might be something that's cultural or so, but it was striking because we did find a definite improvement. And so 50% of the circumcised patients reported using topical steroids after the procedure still. So that's the other thing that I learned, is that even if you're circumcised, like most of the circumcised, obviously this is a selected group. So even if you say most of the people that are circumcised probably, didn't have a disease burden where they were, motivated to join the group, this self-help group. And there are patients that have disease and symptoms after they are circumcised. These are not necessarily all healed. And so in the circumcised group, there were slightly more patients that used topical therapy, and of these, some used topical steroids and other used immunomodulators. But again, there were no significant differences, probably because it just didn't reach a significant because of the numbers that we had. So in conclusions, male genital lichen sclerosus may lead to phimosis, pain, and sexual dysfunction. Circumcision is recommended as first-line therapy, but its effect on sexual quality of life has not been systematically assessed. It does seem that in men with lichen sclerosus of the foreskin, circumcision was associated with improved sexual quality of life and symptom relief compared to medical therapy alone. However, there are men that even though you circumcise them, they still have symptoms. They still need therapy. They need medical therapy. And this is something where it has modified my practice, because I will tell them, if, I send, like I said, I send all the foreskins that I circumcise off to pathology. When they come back, I used to say, congratulations, you had your therapy, goodbye and good luck. And now I sort of say, this is a chronic condition. It most likely is uh, appropriately treated with the circumcision. However, there is a chance that this may come back, and I think the parents need to know this. And if your boy has white patches, myelostenosis, scarring, itching of the glans penis, then please come back, and then we'll have to look at it, because in some few cases, the lichen sclerosus can still come back. It's a chronic disease, and I think that's one of the thing that I've learned through this study, and where it has modified my general practice. So the take-home messages: circumcision men with foreskin predominant lichen sclerosus associated with significantly improved sexual quality of life. I think you should do this in all these men, and you should counsel them appropriately with as such. And it is associated with better quality of life, sexual quality of life, and some symptom relief compared with conservative management. And I think, like I said, this supports circumcision not only as a disease-modifying intervention, but also as a means to improve the sexual outcomes and the sexual quality of life. This is my team. Thank you very much, and I'm open for questions.
Okay, thank you very much, Oliver. Very interesting. I'll invite people now to send in their questions. Whilst people are doing that, a quick reminder that you will get a survey at the end of the webinar when it finishes. You can fill it in immediately, or you will also get an email about, I think, an hour afterwards. You can fill it in via the link on there as well. This webinar is accredited, so if you do wish to get your CME certificate, you just need to complete the survey within 2 weeks. We'll send the certificates out after that period then as well in about 3 weeks' time. Yes, okay, we've got one question come through. So Oliver,
Yes,
I'll just
so one of the
Yep.
questions Alexander Springer says, is there any intraurethral corticosteroid applications available? So I read a lot about this and I could not find any. But of course, if you have meatal stenosis, I think, or urethral disease, it's usually not so much the urethra that's affected, but the meatus. Then I think that's a you know, I I can see where that is an interesting application. So that is definitely something to look into. Otherwise, just topical steroids, high potency, mid potency steroids would be the right thing to do. And the next question is there any urethral FK506 applications available? Same thing. So immunotherapy is definitely one of the mainstays of treatment. And a lot of these patients also, have either, pylomicrus or um, uh, what is the other one? Pylomicrus. Yeah, but these types of immunomodulators. And but I haven't read of intraurethral application. Um, in the majorities of EU countries. Well, obviously, are there the same treatments available over the course of lifetime in the majority of EU countries? Obviously, steroids are very available everywhere, and I think that would be my first line treatment. And but the others, I think it depends a little bit on your system. And the other question is, of course, also whether insurance pays for them or not. In Germany, if you have a diagnosis of Lichen sclerosus, you usually get the immunomodulators paid by. How do you manage physiological phimosis in children? Well, physiological phimosis, I usually don't manage at all. I try to counsel not to have any surgical therapy because we expect it to get better with time. So usually we do not perform circumcision unless the physiological phimosis becomes pathological phimosis. And then, by the time, usually at 4 or 5 years of age, if you can't retract the foreskin, then I do circumcision. Depending on, it's a lot of cultural issues, and obviously, circumcision is such a emotional discussion, at least here in Germany. I give them the option of steroid cream, betamethasone cream for a month, and if that gets better, then some of them don't want to have a circumcision. Others go right for circumcision. They don't want to deal with steroid application. And that's fine with me. I'm also very open to, I realize that, there's different cultures, and some cultures, circumcise their boys, and they've done it for 5,000 years. And there may be some conventional wisdom to it. Certainly, we here in Germany, usually there's actually publication. So between 3 and 5% of boys actually get pathological phimosis, where they need some kind of intervention, be it medical through steroids or surgically through circumcision. And that's a high number. If one person in a school class needs the intervention, that's a pretty prevalent disease. So I think if somebody comes to me and says, listen, in my culture, this is something that we do, um, I I will send them to the office-based pediatric surgeons because that's what their livelihood is. But if I'm doing another procedure like a inguinal hernia or some other, or even something more complex, I'll do it. And obviously, in all the kids that have urologic malformations, and a higher risk of UTI, we perform a circumcision and then also a physiological phimosis. I think is should be circumcised in those cases. So that's how I manage physiological phimosis in children. Do you have information on when the men were diagnosed with BXO as children or as adults? If so, did they differ in disease course? So that's a very, very good question. So we asked, when were you diagnosed and by whom were you diagnosed? So of this collective, only about 10% were diagnosed in childhood. The rest were diagnosed in adulthood, and half of these adults were diagnosed by urologists, and half of them were diagnosed by dermatologists. And there was a trend. I mean, the problem is that the numbers are so low, but there was a trend that those that were diagnosed by a dermatologist were more medically treated, and those that were diagnosed by urologists were more surgically treated, which does not surprise any of us, but it means that it kind of, what everybody should actually get the same type of treatment. There are guidelines and everything, but there is a difference depending on where you end up. So whether you end up in the dermatologist or the urologist, you seem to get a different treatment, which I think would be part of why we have things like EUROGEN to, bring out guidelines and make it clear that, it should not be where you end up. It should be what you have, and you should be treated as an individual, not as someone who goes to one doctor and gets one treatment or goes to the other doctor and gets another treatment. What do you do when the entire glans penis is affected? A very, very good question. So the question is, of course, when it is affected. So in the beginning, and again, I'm from the perspective of a pediatric surgeon, but if you have glandular affection and you do a circumcision, one of the factors that we think or that we know propagates the lichen sclerosus is moisture. So being non-circumcised means that you have trapped urine, and trapped urine is one of the factors that propagates the disease process. So if you do a circumcision, it not only works because you're taking away the diseased organ, the foreskin, you're also, exposing the glands. The glands is going to be it's going to be drier. It's not going to be bathed in so much urine, and that will be beneficial for the disease process. The other thing that we know is that that squamous epithelium, as is the epithelium on the glands, that has more layers, is less affected by lichen sclerosus. So uncircumcised men have skin that is not as thick, is thinner than circumcised. They just have more layers, more horn layers, and that probably is also protective. So I think what you should do is circumcise, watch, see how it goes, and how the disease progression is. And if after a month or 2 or 3 there is still disease, then I think you should, then you should consider long-term therapy, chronic therapy. Now, I don't think there's anything wrong with, having the circumcision heal up, and then if you really think there is more disease, to start it earlier. I don't know enough about it, honestly. Usually, like I said, most of the boys that I circumcised, they were cured. But I'm kind of kind of a little bit hesitant to give them pass. I think this is something that we have to look at, and that's why I counsel them accordingly. Thank you. Back to the Ukrainians. Okay, well, our friends in the Ukraine, I know you guys are in a tough situation, but we're supporting you. EUROGEN is supporting you, and we are supporting you. And there's no option. We gotta win against the Russians. There's no other option. That it's pure evil what is going on in your country, and there's no way of there's no discussion with evil people. You just have to show them who's the boss, and we ought to do that. What is that? We're digressing. Oh, digressing. Digressing. Okay, so what is the recommended approach in broader penile affected skin? Yeah, so consult with a dermatologist. I think that's a good idea. I think this is a disease that needs multidisciplinary attention, and certainly if I had a patient that had chronic lichen sclerosus, I would say you need to see a dermatologist, because it's a multidisciplinary issue, and you can't. What are you going to do? A total degloving of the penis? That'll severely limit the sexual quality of life. I'm not aware of any transplantation or anything like that. I wouldn't be aware that would even help, So definitely, if you have a difficult case, absolutely work together with a dermatologist. And significant number of men with and without hypospadias and LS and lichen sclerosus, leading to meatal stenosis and urethral involvement. What's your experience, and how many of your patients end up on a regimen of autodilatation? We don't, Dr. Ravashted, are you a pediatric surgeon or an adult surgeon? We do a fair number of hypospadias, but honestly, I'm not aware of that association. That is fascinating. You should look. I have not read about that, because I thought hypospadias, intuitively, I would have thought that that hypospadias could be protective, because you don't have a closed, they don't get, they have everything else. They have curvature, and they have scarring, and they have everything, but they don't have phimosis. But I guess that would be interesting. I think you should look into that. Maybe if you have a fair number of them, of men, maybe you should write it up, because I'm not aware that is a risk factor, and it may be, and it would be interesting to see. And I don't autodilatation. I'm a pediatric surgeon. I don't do that. In cases of meatal stenosis, we do dilatation in the OR. We do meatoplasties, but we don't do autodilatation or parental dilatation. I think that would be very traumatic. I think you can do it yourself, but you can't do it on a kid. You shouldn't probably do it on a kid. Alexander, good to read from you. Hear from you. It's great. Follow up. How long? So, good. Frank Martin, great to read from you. What is my recommendation? I don't follow. If I have a kid with lichen sclerosus, it's so common. It's 10% of my circumcision. Granted, thank goodness I don't do circumcisions every day, but it's a fair number of. I don't have them come back to clinic, but I make sure that everybody in the family understands that they have this disease. I do print out the the path report. I take a yellow marker. I show them. I say this is something to watch. Most likely, your child is cured and doesn't need anything else. But should there be, and then I write it down, white patches, excessive pruritic lesions, itching, pain, then please come back and then we'll look at it. I think that's all you have to do. Otherwise you just go crazy of all these circumcised kids that show up in your clinic. And Yazan Iravashte, you're both. That's great. I really think you should look into it. Maybe write up your series if you have a few of those. That is fascinating. I haven't read anything about it, but thank you so much. Those are great questions. Really awesome. Thank you so much. Really, it was a pleasure.
Yes, thank you, Oliver, for taking the time. There's quite a lot of questions there, so thank you for taking the time to go through those. So I would say if anybody has any other questions, if you think of them afterwards, you can also email me and I can pass them on. If anybody's watching this on YouTube, please put any questions you might have in the comments and we will pick them up at when we look next. So I would just before we finish, I would say just a reminder again about the survey. If you do want your CMA certificate, please get it filled in within 2 weeks. But please, everybody else can fill it in as well if you're not worried about that, just because it's useful to get the feedback. Please check our website, EUROGEN website, for future sessions. There are a couple more on there already that you can register for. But I would say thank you to everybody for attending, and thank you for your questions. And mostly, of course, thank you very much indeed to Oliver for the great presentation and taking the time to answer those questions. Yes, thank you. I'll leave a final comment for you, Oliver.
Well, thank you so much again. There's another comment, and I think, some people, we don't see unoperated male hypospadias much, but, that is something that you guys need to look up and write up because it's really fascinating. And thank you so much for listening. It was such a pleasure. It's such a pleasure and and a privilege to be part of EUROGEN and to discuss this with you. Thank you so much for all your thoughtful comments and questions. And see you around. Bye.
Thank you, everybody. Take care, everybody. Bye bye.